No, sir, 1 minute. Now we are live, sir.
Yeah, please start.
Yes, sir. Good afternoon, everyone. Hope you are all doing safe and good. I am Tarun Kumar, organizing chairman of MedInvite 2020, now moderating this session. So today our topic of the session is a challenging differential diagnosis, inflammatory bowel disease, IBD versus gastrointestinal tuberculosis. So today we have our honorable speaker, Dr. Vishal Sharma, who is currently the associate professor of gastroenterology at Postgraduate Institute of Medical Education and Research, PGIMER, Chandigarh, India. So his primary interest was clinical work in field of abdominal tuberculosis and inflammatory bowel disease, and he is an expert in systematic reviews and meta-analysis. So Sar completed his graduation MBBS from UCMS in the year 2005 and completed his post-graduation MD General Medicine from the same college UCMS. And he has done DM Gastroenterology from PGIMER in the year 2013. So his main area of interest was inflammatory bowel disease, including ulcerative colitis and Crohn's disease and gastrointestinal tuberculosis. So Sar was awarded with Dr. S.R. Naik Memorial Award for the year 2020 for best publications in the calendar year. And Sar was also awarded with Dr. Om Prakash Memorial Award 2017 for Young Investigator by the Indian Society for Gastroenterology. Sar was also awarded with Srimati Pawan Kumari Jain Award 2017 of Association of Physicians of India Delhi State Chapter for work in abdominal tuberculosis. Sar also awarded with Dr. M.G. Shah Memorial Award 2020. Sar has numerous publications in very good impact factor journals in his credits and also been the editorial member in many reputed international and international journals. So looking forward for the event, sir. Please take the stage.
Okay. Thank you for your kind words of introduction. And I'm very pleased for your kind invitation and the opportunity to speak today to you. I understand that most of the listeners would be either in the later part of their undergraduation or early postgraduates. So what I have tried is to simplify this, I would say, slightly complex topic. And I have not given too many details, but as a clinician, whatever information is required to deal with such patients, I've tried. So I'll not be, going into too much of the details, but I will try to present a bird's eye view and cover the important aspects by which you could make a clinical distinction between these two disease entities. I hope my slides are visible.
Yes, sir.
Yes, sir.
Okay. So, as I said, that the task which I have today is to talk about gastrointestinal tuberculosis and how to differentiate it from inflammatory bowel disease. I do not have any relevant conflicts of interest, except that I have an interest in both of these disease entities as a researcher. So, the outline is fairly simple. I will introduce people to inflammatory bowel disease, and then how to differentiate Crohn's disease and ulcerative colitis. The second thing which I plan to do is to talk about the various manifestations of abdominal and basically the gastrointestinal tuberculosis. And eventually we'll talk about how to differentiate gastrointestinal TB from inflammatory bowel disease, and this will be, of course, Crohn's disease in all practical purposes. So, if we begin, then let's start off with inflammatory bowel disease. And as we know that there are two operative words, inflammation and bowel. So, it is an inflammatory condition of the gastrointestinal tract, which may manifest in various forms. So there could be some clinical manifestations and there could be some morphological features. Now, if we proceed from here, who are the individuals who develop inflammatory bowel disease? So it's a combination of genetic predisposition, some inflammatory response which gets auto-regulated, which is not regulated in a proper way, and there is a dysregulation, which results in chronic gut inflammation. So an individual who is genetically predisposed, and then there is an exposure to certain antigens, which all of us would be. But because this person is genetically predisposed, he or she may mount an inflammatory response which is more than the usual. So we have gut inflammation which is always present. And usually that is a very well-regulated kind of an inflammation. But once it goes overboard, you may have features of inflammation like hyperemia, ulcers, etc., which appear, and that is inflammatory bowel disease. Now, broadly, if we see that there are two forms, and my focus as far as IBD is concerned is to help a clinician or all of you understand how to differentiate these two entities. One is ulcerative colitis and one is Crohn's disease. So these are the kind of two big groups, but there are certain patients where it may not be possible to differentiate. And the term that we use is unclassified IBD or IBD unclassified. So you have run the tests, you've done the colonoscopies, biopsies and all, but still you cannot say it is ulcerative colitis or Crohn's disease, you say it is IBD, unclassified. But if a pathologist, even after a colectomy specimen or an examination with colectomy specimen is unable to differentiate or discriminate if it is ulcerative colitis or Crohn's, that is labeled as indeterminate colitis. I hope I'm very clear on this. Now, let us understand each of these two entities. So, ulcerative colitis is a disease which begins in the rectum and then proceeds proximally. And this proximal extent is variable, right? So you could have only the involvement of the rectum, the proctitis, you could have the left side colon which is involved, that is left-sided colitis, or you could have extensive colitis which goes beyond the splenic flexure, and sometimes it involves the entire colon, that is pancolitis. But rectum is always involved. It is a diffuse process. So once it starts, till the extent that it involves, it is a diffuse involvement. There are no skip areas or areas where there is no involvement. So that is the classical description of ulcerative colitis. And as the name says, colitis, so it involves only the colon, right? On the other hand, Crohn's disease. Crohn's disease is typically, it spares the rectum, and the ulcers or the inflammatory findings are patchy. So some of the areas will be involved and there will be normal mucosa in between the various sites of involvement. And that is what we call as skip lesions, right? Now, if you see, the ileum is also involved, and it can also involve the colon. And in fact, it can involve any part of the GI tract. The most common site is the ileocecal area, but it can involve only the small bowel, sometimes only the upper GI tract, that's the duodenum or stomach, maybe the only sites of involvement. And it can involve any part of the bowel. Of course, both of these diseases also have extraintestinal manifestations. Then, if we were to differentiate, I think very, very clear, these two images. Starts in the rectum, ulcerative colitis. Rectum is spared, Crohn's disease. Diffuse involvement, ulcerative colitis. Skip areas of involvement, Crohn's disease. Ileum usually not involved. There may be some 5 centimeters of involvement in form of hyperemia, which is known as backwash ileitis in ulcerative colitis. But the ileum may be involved with ulcers, and in fact, even the jejunum or other areas could be involved. So that's what we call as Crohn's disease. Now, this is a picture I created for this lecture. So in ulcerative colitis, you can see this is the gut mucosa, submucosa, and then there are various layers of the GI tract, only the mucosa is involved in ulcerative colitis in most of the patients. Whereas in Crohn's disease, you can see the mucosa, submucosa, even the muscularis propria, all of these can be involved. And that is what we call as transmural involvement, right? So this is only the mucosal disease. This is a transmural involvement. What are the morphological manifestations, anatomic manifestations? Ulcerative colitis, you can see this is the colon. The entire colon is involved. And there is inflammation, hyperemia, there could be some ulcers there. But in Crohn's disease, there are ulcers, and in between, the mucosa is normal, right? Then, this is the inflammatory subtype of Crohn's disease. Crohn's disease has three variants, I could say, or the behavioral pattern of Crohn's disease could be inflammatory. That is, ulcers, erosions, those kind of findings. Or there could be formation of strictures. And that is a narrowing in the bowel. And then there could be a proximal dilatation. So this is the second type. The third behavioral type is the fistulization. That is between the two luminal tracts, like let's say the ileum and the colon, there could be a fistula. Between the jejunum or the ileum, there could be a fistula, or the jejunum or the colon, there may be a fistula. A lot of perianal fistulas could be there. So that is fistulizing disease, right? And this could be an enteroenteric, that is bowel communicating with bowel, or enterovisceral. There could be some visceral organs which may communicate with the bowel, that's enterovisceral. Or there could be a enterocutaneous fistula, fistula between the bowel and the skin. So that is enterocutaneous fistula. So these kinds of fistulization may occur in Crohn's disease. So three patterns of Crohn's disease, and one is inflammatory, stricturing, and fistulizing. Now, so here you can see these are endoscopic images of ulcerative colitis. All of the bowel is abnormal, right? And the entire bowel that you see is normal. There are no skip lesions, and then you can see an ulcer. So this is abnormal. You cannot see the vessel walls, but and this is a kind of a diffusion. And this is again surgical colectomy specimen. And here you can see from the rectum, this is a diffuse involvement till the mid-transverse colon. And this is a diffuse kind of involvement, and this is the uninvolved, right? So you see a very diffuse kind of. On the other hand, Crohn's disease, you could have areas which are involved, and then there is another area which is involved. And in between there may be a normal area, and then there could be a fat area which may happen. Now coming to histological findings, and if you see these charts, you can see that there are certain acute changes which happen immediately with the inflammation. So there may be formation of mucosal breaks which are deep, and there are inflammatory cells, that is an ulcer, right? Next, you could see certain other changes. So you know that normal colon has crypts. Now, these crypts may have inflammation, which is known as cryptitis, or when there are a lot of neutrophils, it may form a crypt abscess. But there are chronic changes also, which develop over a time, usually more than 4 weeks. And this could be that the crypts have become smaller, or there is a loss of the crypts, or the crypts have started having morphologic changes. So rather than the usual pattern, you have a branching kind of a lesion. These are chronic changes which happen after the inflammation stays on for some time. This can happen in IBD also, and even in tuberculosis. Nothing specific for any disease entity, only suggesting that the inflammation is now a chronic kind of a process, right? And then there are certain changes which are more specific for Crohn's disease. So you could have non-caseating granuloma. So granuloma is a constellation or an area or a nodular kind of an area where there are inflammatory cells. You can see here epithelioid histiocytes, which kind of macrophages, and then there's a rim of lymphocytes. And then there could be Paneth cells, which are not usually seen in colon, but in Crohn's disease because of inflammation, they may be seen in colon, and that is Paneth cell metaplasia. Both of these findings are considered to be specific for Crohn's disease. So how will IBD manifest? So you can see that since the ulcerative colitis involves the rectum, you will have bleeding from the rectum. You could have, because of the rectal involvement, rectal symptoms. So urgency, because rectum is the reservoir of stool. So if it is inflamed, the stool cannot stay there for a long time because of the inflammation. And the patient has an urge to pass stools again and again. So that is urgency, frequency, and some amount of pain during defecation, right? And then, of course, there is bleeding per rectum. Some of these patients, a small number, may have constipation. But Crohn's disease, on the other hand, because of the ulcers which are in the ileum and usually the rectum is not involved, you have diarrhea. More the ulcers, more the chances of having diarrhea. Bleeding is much less common. It can happen in around 20% of patients, but much less common. And then, because of the formation of the strictures, you could have abdominal pain, right? And because of the fistulization, there could be other manifestations like, let's say, infection, if it is extracolonic kind of a stricture, or there may be a diarrhea if it's, let's say, an idiocolonic stricture, because the contents will immediately move from small bowel to large bowel. So now we know the differences in the clinical manifestation. Ulcerative colitis, bloody diarrhea; Crohn's disease, pain, intestinal obstruction, and chronic diarrhea, usually without bleeding, right? Now, stricturing Crohn's disease, and I just want to show you some images of the CT scan. So you can see how there is a area which appears more enhancing than the usual bowel wall, and it is a dilated segment with a stricture, a narrowing here, and that is a stricturing Crohn's disease. Again, if you look at this patient, you have a hugely dilated bowel wall, which is enhancing on the MR, a contrast MR, and this is a because of a stricture here. And if you see further, then you can see that there are communication with this is the bladder, urinary bladder, and there is an enterovesical fistula. And in fact, there is a communication with the ileum also. So there is an ileocolonic fistula also. So this is a fistulizing Crohn's disease. Again, ultrasound is a very upcoming modality, and that is why I have shown these images. You can see that this is the bowel wall, which is enhancing, and this is the water or liquid inside the bowel, and you can see that this is a narrowing, right? So this is and then there is some increased vascularity because of the inflammation. So these are the findings which you could see on an ultrasound, right? And then this patient was eventually operated, and then you can see that there is a hugely dilated part of the colon, which was also visible on the X-ray, and then there was a stricture here. You can see the narrowing. This is the gas, and then here you can see a narrowing, and you can see very nicely the stricture, which was here, a 4 centimeter long, fairly long stricture, right? So these are the findings of Crohn's disease. Now we classify ulcerative colitis and Crohn's disease. For ulcerative colitis, we describe the activity. I'm not going into the details, and then we will describe the extent. The extent I've already talked about. So activity, there may be any negative disease. That is because of medication or because of inherent disease, let's say activity. A patient may be in remission, may not have active disease. But there may be some amount of activity, or there may be an increasing level of activity. And S3 is the patient type of patients who will need a remission because they also have systemic toxicity apart from large number of bloody stools. Then I talked about the extent already. And then for Crohn's disease, you have age, behavior, and location. So age, whether the onset is at less than 16 or 17 to 40 or more than 40. Behavior, I think I've already talked about. B1, B2, or B3 disease, and then there's a perianal disease. Location, it could be ileal location, colonic location, ileocolonic location, and some of the patients may have a restricted upper GI involvement. So I think I have talked in great detail about ulcerative colitis and Crohn's disease, and I have tried to, talk about how to differentiate these two entities. And I think that even people who were not, let's say, who were not exposed to IBD before this lecture should be able to understand now the differences in the involvement and the clinical manifestations. to ensure that we are focused on the clinical aspects, I've tried not to discuss too much of pathophysiology. I think the role of the clinician is to diagnose if it is IBD or IBD mimic. So there are a lot of diseases which mimic IBD, right? And one of them is tuberculosis, which we are going to talk about after this. Once you have ensured that this is IBD, you say whether it's an aggressive disease or a mild disease. And then I think this is beyond this lecture today. But then you then decide whether it's aggressive disease you want to treat with a biological agents, or you want to treat it's not a very aggressive disease and you want to use the traditional therapies like ASAs or immunomodulators. And eventually you also prognosticate the patient, educate the patient, vaccinate the patient, look at the bone health, mental health of these individuals. But all of this is beyond the scope of the lecture today. Today we just want to focus on what is IBD, and we want to be sure that this is not tuberculosis, right? Now, the next thing I want to talk about is gastrointestinal TB. And if you look at it, then it is one of the more common forms of extrapulmonary TB. In fact, certain reports suggest that it is the third most common type of EPTB, where others suggest it is the sixth most common, but typically around 10 to 20% of all EPTB cases are abdominal tuberculosis, right? Then this is something we did. We did a survey of practices, and that is, I wanted to bring this survey here so that we must understand why we want to know more about TB. Because in India, TB is a problem. So you will definitely encounter, if you're practicing, patients of GITB. There's no confusion about that. And IBD is rising because of the Westernization and changes in lifestyle. The inflammatory bowel disease is rising, and certainly you're going to encounter it. And there will be patients where you will be asked to say whether this is TB or Crohn's disease. And if you see, just look at the variability in practices. And I think you will understand once we are at the end of this lecture that how diverse the practices are. There is evidence and data to say that 6 months of TB treatment is usually okay. But you look, around 50% of people, or physicians, including physicians, gastroenterologists, surgeons, 50% or more of them will treat for more than 6 months, 9 months or 10, 12 months of not needed. But I think there is a role for education regarding GI TB. And therein, I think the importance of this lecture that we are having today. So GI TB could be a peritoneal involvement. So we have a peritoneal cavity, and once that involves, usually it presents in 80 to 90% patients with ascites, formation of ascites. Some of the patients may have just omentary nodules, peritoneal adhesions, and things like that without ascites, but broadly, largely, and mostly, it is presence of ascites. Luminal TB, that is the involvement of the intestinal tract, also known as intestinal TB, and many people use the term gastrointestinal TB for this particular form of TB. So it could be any part of the GI tract. Today, the focus is on intestinal and perineal involvement. Of course, there may be involvement of the lymph nodes. I'm not going to discuss this today. And then there could be involvement of the visceral organs like the liver, pancreas, spleen. But again, we're not going to discuss this today. Now, the focus is intestinal TB, which is also sometimes termed as gastrointestinal TB, and the most frequent site of involvement is ileocecal area. And as you go caudally, as you go cranially, or as you go caudally, the frequency of involvement keeps decreasing. So, ileocecal area followed by ascending colon, terminal ileum, and then rest of the areas. So these are the areas where the involvement is maximum. Why ileocecal area? Because there are multiple reasons. One is because it's an area of relative stasis because of the ileocecal wall, a lot of lymphoid tissue, less amount of acidity, which can damage the mycobacteria. So that's the area where a lot of cases have involvement. Now there are various morphological types. How does the disease appear anatomically? So you could have ulcers, and sometimes you could have ulcers at different, and I'll show you a lot of images of ulcers later on. And then there could be formation of mass lesions, or there could also be formation of strictures. So ulcerative form may be there, hypertrophic form may be there, or a stricturing form may be there. So ulcerative form, because of mucosal involvement, it presents usually as diarrhea. Very rarely it may cause bleeding. Sometimes it can cause perforation. Tumoral forms, or the pseudo-tumoral forms, or the hypertrophic forms, usually present with pain and intestinal obstruction. And again, they can have perforation because of the distension. And the stricturing usually presents with features of intestinal obstruction. Again, constitutional features, especially if you are in loss of weight and appetite, are common in around 50 to 60% of these patients. So how do you define a case? So this is a very old definition I just brought in. Classically, you could have granulomas or tubercles with caseating necrosis. You may have demonstration of the mycobacteria, acid fast bacilli positivity. You could have typical operative findings which surgeons use with a histology which is suggestive from the mesenteric lymph nodes which are excised, or you may culture them. But if you use only these criteria, the positivity in GI TB will be only 20%, and you are going to miss 80% of patients because it is usually a posi-mycobacterial disease, posi-bacillary disease, and therefore the mycobacterial positivity is in a limited number of patients. Therefore, you need additional criteria. And this additional criteria was given in 1969 by Lokai. So you could have diagnosis of anorectal, and this is now, let's say, also extrapolated to gastrointestinal TB. You could have AFB positivity, which is definitive. Again, you could have culture positivity. Nowadays, also PCR positivity or gene expert positivity, which is definitive. Or you could have caseating granulomas, which is very, very suggestive. If it's a granuloma, you are not very sure because there are many causes of granuloma. But if there's a caseating necrosis, very, very certain that that is TB. Or you could have what is known as a probable TB. So you have ulcers, let's say you have a granuloma. That could also be Crohn's disease, right? I told you that non-caseating granulomas are present in Crohn's disease. So in that probable situation, when you're not sure, Lugan suggested that look at the response to treatment. And if you see improvement after giving ATT, you say that this is TB. And if you don't see an improvement, you say it is Crohn's disease. But what is the definition of improvement? I think that is also very important. And some of the subsequent slides we're going to talk about. So how do you define a case? The Indian extrapulmonary TB guidelines either say it's a bacteriologically confirmed case, so you have a positive microbiology culture or a validated PCR like gene expert, or you have a clinically diagnosed case. Let's say these microbiological tests are negative, but you say that the clinical symptomatology is suggestive, and then there are other evidences in form of granulomas, and then you start saying that this is a clinically diagnosed case. How long would you want to treat? So that's very important message to all of you. 6 months of antitubercular therapy is okay. It is enough. In fact, the clinical cure rates are very, very similar whether you give a longer treatment or a shorter treatment. And also there are no differences in the relapse rates between a longer therapy or a shorter therapy. So in our center, we use 6 months of treatment for most of the cases. Is there any role of steroids? No. As of today, there is practically no role of steroids in antitubercular therapy. There is some old data which we tried to summarize in this meta-analysis which we did, that in peritoneal TB, it may reduce the number of patients who have intestinal obstruction or pain or features like that. But in an occasional patient, you may want to use it, but broadly, there is no relevance of this particular, the use of steroids. Now, the treatment completion rates, because, it is very important that individuals who start on treatment complete the treatment. And if you look at it, the treatment completion in abdominal TB is 76%. In CNS TB, very low, 64%. But not as high as 90% in lymph node TB. That is because many of these people will continue to be symptomatic even when they are treated for tuberculosis. And why is that so? That is so because some of these develop strictures. So the ulcers will heal, but the strictures might stay. And so this is data from All India Institute of Medical Sciences. If you have 106 patients, they had 106 patients with TB strictures and with ATT. The resolution of pain was only in half of them. So half of them will continue to be symptomatic. And these are the patients who may need dilatation or treatment of the stricture using endoscopy. So you can see this is a narrowing, very, very narrowed area of the bowel. And then you pass your balloon through the endoscope, and then you dilate this, and eventually that results in opening up of these strictures. Of course, there may be some risk of perforation, etc. But this is a very good modality to treat those strictures which can be endoscopically accessed. Otherwise, these patients would need surgery if this is a very long stricture or the multiple strictures or it is not reachable endoscopically, right? Now, if you see what are the conditions when you need surgery or any intervention. So when there is unrelenting or recurrent obstruction or not treatable with I would say the endoscopy, you need surgery. If there is a perforation at presentation, or if there is a massive GME, which is uncommon. Now, I have talked about inflammatory bowel disease. I've also talked about the clinical presentation and treatment of tuberculosis. So as you can see, the intestinal TB is usually an ulcerative or a hypertrophic form of disease, which may involve some certain parts of the bowel. And it could be small bowel, it could be large bowel. And typically it is not a diffuse involvement. It is one area which is involved, and occasionally there may be certain other areas which are involved. So this is a disease which mimics Crohn's disease. And usually ulcerative colitis can be easily discriminated from tuberculosis or Crohn's disease, right? But the problem is differentiating Crohn's disease and TB, because in India, why is this important? We must understand why this is important. Because even in countries where tuberculosis is not very common, and this is data from South Korea, you can see that there is a lot of misdiagnosis rate. 18% of Crohn's disease patients were misdiagnosed as TB. And 11% of TB patients were misdiagnosed as Crohn's disease. Now, why is this very important? If you diagnose a person who actually has intestinal TB and start treatment for Crohn's disease, what is the treatment for Crohn's disease? It's usually steroids. The steroids or immunosuppressants like anti-TNF, biologics. Now, the TB is going to flare. On the other hand, it has also been shown that if you treat Crohn's disease as tuberculosis, there is a delay in starting effective therapy for Crohn's disease, and this may predispose to development of stricturing complications, which may necessitate endoscopic dilatation or surgery. So, both of the misdiagnoses, whether you treat Crohn's as ITB or ITB as Crohn's, have problems, but you have to choose the lesser evil. And the lesser evil here is to treat it as TB, because in India, usually one expects that TB is more common, although in our center, we see almost equal amount of TB forms. And the second thing is that we know the end of therapy rules for TB. So TB, usually the therapy is 6 months. And as I will tell you that at 2 months, you can say after starting ATT whether it is TB or Crohn's. And usually, there may be some delay in diagnosis, but as such, it doesn't really, harm the patient to a large extent. But on the Crohn's, if you start treating TB as Crohn's, then certainly there are going to be adverse consequences of steroids or modulators or biologics. That is the reason in India, if there is a confusion which is not sorted out, you usually start on an ATT trial, right? That is very important to understand. Okay. So, are there any clinical symptoms? So now I'm going to talk about differentiating TB and Crohn's disease using various modalities. So clinical presentation, radiological findings, endoscopic findings, histology, microbiology, and response to it, right? Are there any clinical features which suggest one diagnosis over the other? Presence of fever favors TB. short duration of illness, especially less than 6 months, favors TB. Presence of night sweats, evening rise of temperature, TB. Pulmonary lesions, cavities in the chest X-ray, TB. Presence of peritoneal involvement in form of ascites in patients who already has intestinal lesions, TB. On the other hand, predominant diarrhea, again it can happen in TB, but suggests Crohn's. Bleeding per rectum can happen in TB, but suggests more likely Crohn's. Extraintestinal, joint pains, multiple joint pains, or axial involvement, backache, or uveitis. These things are more suggestive of Crohn's disease. Perianal lesions, fistulae, sinuses, more likely Crohn's disease can happen. So this is nothing 100%. None of the feature, as I said, is very, very discriminating. But still they give you an idea. And pain and intestinal obstruction can happen in either of these entities. Can certain tests help us? So this is an interferon gamma release assay. I think you know about this. These are tests which use the blood of a person, and then that is exposed to TB antigens. And there are different antigens which are used, like E, SAT, etc. And then you look for the release of the interferon. So this is not a test for disease activity. This is merely a marker of previous or current infection with TB. So if it is positive, it could be because of the past infection. So in some of the studies, it has been shown to be having fairly good sensitivity and specificity. So this is a meta-analysis of 5 studies. We are showing a sensitivity of around 75% and specificity of 87% for the diagnosis of TB. And in fact, a recent study showed that if you look at IGRA positivity or interferon gamma release assay positivity, then more than 90% of TB patients are positive, and only less than 10% of Crohn's are actually positive or negative. And if you see the cutoff values, anything more than 100 usually suggests TB and can be used to choose the patients who needs who can be started on ATT. Now, once we've used IGRA, I don't think there is any additional benefit of using a MON2 test. So MON2 has its own problems. It can be positive even if there is some past, vaccination with BCG, etc. So MON2 has its own issues. So one of these one can use. MON2 is much cheaper, but IGRA, you could have cutoffs also, which can help. Now, this anti-Saccharomyces cerevisiae antibody is being used a lot by practitioners. I'm not a very big proponent or a fan of this particular test, because if you see the Indian studies from CMC, from Sanjay Gandhi Lucknow, and from All India Institute, you can see that it is like flipping a coin. So sensitivity is around 50%, 30 to 60%. So you could have positivity in TB also. So it's not a very, very, I would say, even a specific test that matter. So are there any endoscopic findings which could help? So usually right-sided involvement or the involvement of the ileocecal valve or area is more in TB. In Crohn's disease, you have, again, more of the left colonic involvement. Ileocecal may be spared, but it may also be involved. And usually you find multiple segments which are involved, and you can see that there are skip areas or skip lesions, right? Now you can have these rounded ulcers, which are, I would say, perpendicular to the lumen or around the lumen. What you have the circumferential ulcers, that is more favoring TB. Again, more favoring tuberculosis. A gaping ileocecal valve involved favoring tuberculosis. A gaping ileocecal valve involvement of cecum, right-sided involvement favors tuberculosis. Distorted cecum, pulled up cecum, all of these favor tuberculosis. Ulcerated narrowing can happen in both TB or Crohn's disease. So you can see an ulcer and there is some narrowing here. The endoscope could not be taken beyond this area. This can happen in both TB and Crohn's disease. More of these small ulcers, you can see that there is an ulcer and there is a reddish area around this. This is what we call as the ephthalmos ulcer. Often, they are also present in the oral cavity. And these favor more, in Crohn's disease. They may also be there in tuberculosis, but again, more likely in Crohn's disease. Now, these kind of linear ulcers as compared to the round ulcers of tuberculosis. So these longish linear ulcers favor Crohn's disease, right? You could also have deep serpiginous ulcers. So you can see the ulcer very deep, and then it's like a serpentine or like a snake, from here to there. So that kind of ulcers favor Crohn's disease, right? Then again, this is to show you that a linear ulcer in Crohn's disease and a circular kind of ulcer in tuberculosis, right? Pseudo polyps. So you can see that as ulcers heal, there may be formation of these polyp-like lesions, elevated polyp-like lesions. Can happen in both tuberculosis and Crohn's disease. Usually people say more in TB, but can happen in both of these diseases. Now this kind of manifestation, bowel stoning, you can see that there are ulcers, and then these kind of, I would say, mucosal islands, and you can see that this is a bowel stoning which is more frequent in Crohn's disease. So if we summarize the endoscopic finding, the transverse circumferential ulcer in TB, linear longitudinal or epithelial or serpentine ulcers in Crohn's disease, bowel stoning more in Crohn's disease, ileocecal involvement, gaping IC valve, which is kind of opened up, that is in more in TB, pseudo polyps in both, more in TB, skip areas in both, but more in Crohn's disease, and of course the site we have talked about. Now coming to imaging findings, I don't want to go into the details, but you can see here that usually the bowel wall is imperceptible, but you can see that here this black area, and this is the contrast, the white thing is the contrast here, right? So you can see that this is a thickened bowel, and this is a kind of asymmetric, although the entire bowel is thickened, but one side is thickened more, right? And then you can have a thickening like this, which is long segment involvement. And then you can see that some of the area is enhancing white here, and some of it is black inside here. And this is known as mucosal enhancement or a mural stratification kind of a situation. Again, can happen in both, but maybe more in Crohn's disease. So this is a homogeneous pattern, more in TB, but a stratified pattern where there you can see the layers. The layers can be seen. First layer which is enhancing, the middle layer which is not enhancing, and then again a layer which is enhancing. So layered pattern, again a layering here with an intervening fat, more in Crohn's disease. Again, can happen in both, but more in Crohn's disease. Then you can see that this is a thickened bowel, and you can see these vasa recta or vessels which are visible and dilated. So this is like a comb. So you have a hand, this is a bowel, thickened bowel, and then these are the vessels, and this is like a comb. So this comb sign, which suggests that there is a mesenteric vascularity or vasa recta which have become engorged. This is more in Crohn's disease, right? Now you can see that this is a bowel wall here. This is a bowel, and this is fat which wraps around the bowel, more in Crohn's disease. And then right colonic involvement, normal colon here, and then left colon. So this is a skip area. One area is involved, then there's a normal area, and then there's another area which is involved. So skip lesions, this is TB. This is Crohn's disease, right? Can happen in TB also. Then you have lymph nodes. And if you can see, just look at this lymph node. I think this is a very nice image if you look at it. There is an enhancement of the periphery, but the central area is black, necrotic, hypodense center. This is very, very classical, typical of TB, right? You don't get necrotic lymph nodes in Crohn's disease. So this was a meta-analysis done by the All India Institute group. You can see here that they have also said that necrotic lymph nodes are 100% specific for a diagnosis of tuberculosis. And ileocecal involvement suggests the diagnosis of tuberculosis. Sorry. Now, let us also talk about the histology. And if you look at the histology, then of course, you could have granulomas in both of these. But if there are multiple granulomas, so I think I have only 5 minutes now. So I will be slightly quick with the slides. So if you have large number of granulomas or larger granulomas, or multiple granulomas which are together or confluent and then coalesce together, that favors TB. If you have scattered granulomas, single granuloma, no necrosis, that favors Crohn's disease. If you have granuloma in the lymph node without granuloma in the intestine, more likely TB, right? So there are three findings. If you find, they suggest TB. A granuloma which has a caseating necrosis, a granuloma which is a confluent granuloma, multiple granulomas joining together and form larger granuloma, or when the ulcer base is lined by epithelial histiocytes. These are very specific for TB. But again, the sensitivity is less. All of these findings are present in less than 50% and usually not more than a quarter of the patients. Now, coming to the microbiological tests, TB is a possibacillary disease. And therefore, even if you have a negative microbacterial test, it may not exclude tuberculosis. AFB positivity is very, very infrequent, usually less than 10%. Culture positivity, less than 50%, usually 20-30%. Antigen tests are not really been tested and very poor sensitivity actually in a couple of reports. So, but you should also sample other areas. I mean, if there are things in the chest, get a sputum test, right? The lymph node in the periphery, get that sampled. What about the PCR? Now, PCR, there could be multiple probes which could be used, and typically it is IS6110. It has a sensitivity of around 45-46% and a specificity of 95%. So again, less than half of the patients. The gene expert, this is a meta-analysis we recently published. And you can see sensitivity only a quarter of the patients. Very specific, but very low sensitivity. So low sensitivity is the Achilles heel of mycobacterial tests. Then there are a lot of models which take a lot of multiple parameters and try to combine them. I'm not going into the detail, except mentioning this one single model, which is a multi-parameter Bayesian model. And this uses a combination of clinical, endoscopic, pathological imaging, and serological parameters and may give you a probability. But the probability is dependent upon the local disease prevalence. And you may not always have data for the local disease prevalence. But this is one of the better models, and this is available online for people who would want to use it. Finally, you start, if you are still not very clear whether this is TB or Crohn's disease, you start treatment for TB. And then you do an endoscopy again at end of therapy. And you see that all the ulcers heal in TB, whereas ulcer healing does not usually happen in Crohn's disease. But the clinical symptoms may improve even in patients with Crohn's disease because of ATT. Antimicrobacterial therapy can improve clinical symptoms in Crohn's disease. Therefore, one must not trust clinical improvement, that there is an improvement in pain or diarrhea with ATT does not mean that it is TB, it could be Crohn's disease. So do an endoscopy, colonoscopy again, and look at ulcer. But the problem is that if you do it late, the endoscopy late, then the disease may progress. If it is Crohn's disease, there may be a more risk of stricturing disease, and there is a higher risk of surgery. Therefore, what we did at our center, we started doing endoscopies at 2 months, and you can see that at 2 months, you could see the healing of ulcers. And that is what we call as early mucosal response. So I think I have already talked about this, but there may be patients who may not want a colonoscopy because at many centers, anesthesia may not be available, and patients, it is a painful procedure. And therefore, they may not want a repeat endoscopy or colonoscopy. So you can keep looking at biomarkers. So calprotectin, fecal calprotectin is a biomarker done in the stool. So this is a protein which basically is a neutrophilic protein, and it increases when there is inflammation or ulcers in the colon of sometimes even the ileum, right? Not a good marker for ileum, but certainly a good marker for colonic disease. And if it is elevated at the baseline, then the decline may suggest that there is healing of the ulcers. And in patients who continue to be symptomatic or do not have a decline in calprotectin, you may choose to do a colonoscopy in only that subset of patients. So this is the strategy that we follow at our center. If there is a diagnostic confusion, even after battery of tests, colonoscopy, biopsy, culture, gene expert, even after that, we are not sure, we start on ATT and we do a colonoscopy at 2 months for most of the patients. If there is no response or the ulcers are not healing, you reassess the diagnosis, consider Crohn's disease and exclude drug resistant TB. On the other hand, if the ulcers are healing, you continue ATT for 6 months. If patients do not want a colonoscopy, repeat colonoscopy, you may do a fecal calprotectin or a C-reactive protein or combination of these. Again, only those patients where these are elevated at baseline, which would be a large majority of patients. What is in the future? I think future is using less invasive modalities. Biomarkers, of course, we are using. Maybe use of some imaging modalities, contrast ultrasound is coming up in a big way. There's some data on T regulatory cells from All India Institute needs to be proven, or use of AI-based technologies to differentiate TB and PONS, and there are some papers which are coming up. So this is what we have in the future, but till then, therapeutic trial of ATT is very important tool for the clinicians. Ladies and gentlemen, I will conclude by saying that TB continues to be a problem in India, and GI TB is a very, very important pattern of extrapulmonary tuberculosis. IBD is rising, and therefore you will be called upon to discriminate intestinal TB and Crohn's disease. And because the microbacterial tests or the microbiological tests, they have a low sensitivity, the confirmed diagnosis is not achieved in almost 70 to 80% of the patients. And then you need a therapeutic trial of antitubercular therapy. And again, you have to reassess these patients using a colonoscopy. Usually at 2 months, you will be able to say whether it was tuberculosis or whether it was Crohn's disease. Thank you for your attention, and I am open to your questions.
Thank you so much, sir. We received a couple of questions from audience, sir. I will let you know.
Yeah. Please.
Sir, before proceeding for the question and answer session,
Sorry, your voice is not clear. Sorry.
Yes, sir. How is it now, sir?
Yeah.
Yes, sir. Before proceeding for the question and answer session, we have our educational partner for our conference, sir, JP and designer. During the question and answer session, you can take the questions and explain the questions to the audience, sir. Just I will play the PPT related to JP. Is it okay, right, sir?
Sorry?
I will just play the PPT of JP, sir. You can take the questions, sir. Yes, sir. We have the question like, sir, what is the gold standard treatment for IBD?
So, there is no gold standard. There is no single gold standard. How do you treat IBD? I think that is the question. And if you look at it, IBD is not one disease, it is 2 diseases. You have ulcerative colitis and you have Crohn's disease. For ulcerative colitis, usually ASAs, that is aminosalicylates, they work, steroids work, immunomodulators work, and then there are biological agents. So you look at the disease, how much is the involvement. If it is only the rectal involvement, sometimes only topical therapies may work. If it is a pan-colonic kind of a disease, you will also need, oral drugs. If it is a severe disease, you may need intravenous medication, steroids. And sometimes not responding, you may need biologics. And usually for ulcerative colitis, we tend to use a step-up approach. We usually start off with the, less costlier drugs, non-biologic agents, and then if there's a need, we may go to biologics. On the other hand, for Crohn's disease, a top-down approach is often preferred, where you use biologics first. ASAs or the 5-aminosalicylates do not usually have much of an efficacy in Crohn's disease. So typically, it is biologics, immunomodulators, and steroids. Now you stratify the course, how severe is the disease? How much is the patient who is symptomatic? What is the extent of involvement? There are various scores to use. You have an endoscopic scoring, you have a Crohn's disease activity index, CPAI, and you try to say whether it's a severe disease. If it is severe, like for fistulizing, you would upfront want to use biological agents. So you stratify the severity and then you treat. And then there's a treat to target strategy. I have not talked about that. You discuss with the patient, you stratify the disease course, and then you select the targets. What are targets to treat? At 6 months, what are the changes or improvements that you are expecting? How much of endoscopic improvement are you expecting? What happens if the endoscopy still shows disease activity? What are the next drugs to attempt? These are complex decisions which you make together with the patient. And while your question is important, I think it is very difficult in a single answer basis, as a question answer basis, to really say that this is the one drug which is the gold standard. I understand that as undergraduates, we are always interested in the MCQs, which which is the gold standard for this. There's no gold standard.
Yes, sir. We have our next question. Sir, please explain what type of drugs like mesalamine, corticosteroids, immunosuppressants should be used in UC and CD.
Sorry, what type
of drugs like mesalamine, corticosteroid, immunosuppressants should be used in UC and CD.
So you want to know that what are the differences, which drugs are effective in ulcerative colitis and which drugs are effective in Crohn's disease, right?
Yes, sir. By the participants. Question from the participants.
Okay, so whenever you treat IBD, there are two situations. One is this person is having an active disease and I want to control the disease, right? That is known as induction of remission. That you want to change the active disease using the treatment to convert it into a remission. That is no active disease. And the second part is the maintenance of remission, right? That once the remission is maintained, some amount of treatment may be needed to maintain at that stage and preventing any disease relapse. So steroids are useful both in ulcerative colitis and Crohn's disease for induction of remission, but not for maintenance of remission. Immunomodulators, that is azathioprine, which is also sometimes known as antimetabolites. Azathioprine, methotrexate, right? These are the drugs useful both in Crohn's disease and ulcerative colitis for maintenance of remission, but not for induction of remission, right? Then mesalamine or sulfasalazine, which are ASAs, they are useful for induction and maintenance of remission in ulcerative colitis. Usually, although they are very frequently used in Crohn's disease, they may not have much of a role in Crohn's disease. Now come the biological agents. Anti-TNF, infliximab, then adalimumab, golimumab. These have benefit both in induction and maintenance of remission in ulcerative colitis as well as in Crohn's disease. Then there are other biologics, anti-integrins, vedolizumab, which is a gut-specific biologic, right? That has role both in induction and maintenance of remission in ulcerative colitis and Crohn's disease. Then there are upcoming drugs, ustekinumab, data for both UC and CD. Now then there are small molecules like JAK inhibitors, and we have tofacitinib, which is now available to our patients for ulcerative colitis induction and maintenance of remission. So each of the drugs you can use in some of the specific settings. Again, you have to see which disease, what is the extent of the disease, whether you're using it for induction and using it for maintenance. So these are the important questions which you need to know before you select a treatment.
Yes, sir. Next we have a question. Why has Westernization increased the incidence of IBD?
Yeah, I think that's a question which we do not know an answer for sure. But the understanding currently is that it is the Westernization of diet. Mediterranean diet or the vegetable-based or the fruit-based diet is protective for IBD. Whereas the Western diet, which is high in lipid, high in fat, is a causative agent for inflammation. And if you see over time, our diet has changed. Our physical activity has reduced. Our diet has changed to high carbohydrate, more of energy dense, less of fiber. So all these are believed to be the harbinger of this transition. And we are actually in a stage where there's an increase, there is an epidemiological transition to a phase where there is an increase in the rates of IBD across the country. So we don't know for sure, but I believe diet plays an important role.
Okay, sir. I think we have no more questions.
Sorry, not clear. Voice is not clear.
Yes, sir. There is no more questions, sir. We can wait for 1 more minute. Like if any audience have any questions, please let us know. Sir will answer. Sir, we have a question. What lifestyle modifications can be adopted to avoid IBD in patients with IBD and also to prevent it? And he is asking for prevention in normal people and also in patients with IBD. What type of lifestyle modifications we need to?
Again, a very, very important question. But we do not have data to suggest that a particular lifestyle change can reduce the risk of IBD. But again, if we were to believe the epidemiological and the animal studies, diet which is plant-based, avoids high carbohydrate, high fat, may reduce the risk. I am not very sure whether that will work on an individual level, but certainly in the community level, it is believed that these kind of diets may reduce the risk. Probably the problem with diseases like IBD, which are multifactorial, is that there is no single thing which works either for preventing it or for treating it, right? So there is no one magic bullet.
Okay, sir. You can wait for more 30 seconds. We can get any questions. Thank you, Ashwin Nair, for the good question. Yes, sir. Next, we have another question. Sir, bowel resection completely cures Crohn's disease?
No. So, very simple to understand. Ulcerative colitis is a colonic disease, right? So, if you remove the colon in ulcerative colitis, the entire colon, that is proctocolectomy, that is curative for ulcerative colitis, right? Proctocolectomy is curative for ulcerative colitis because it is a colonic disease. So you create a pouch of the ileum as a reservoir or as a neorectum kind of thing, and that is what is known as the pouch surgery. So that is curative for ulcerative. Crohn's disease, because it is small bowel, a large bowel, segmental disease, there is no curative surgery. The surgery is a very important armamentarium in treatment of Crohn's disease. So strictures, you can resect the stricture and the patient will be asymptomatic, and then you can keep treating the patient so that there is no recurrence of disease. But please understand that while surgery is a very important part of the therapeutic strategy for Crohn's disease, certainly it is not curative.
Okay, sir. Sir, we have another question. Any relation of lectins in IBD? Any relation of lectins in IBD, sir? Lectins.
Okay, so that's okay. I'm not aware whether there is any direct clinical benefit of leptin or measuring leptins in IBD.
Okay, sir. Sir, this is my personal question. Like you said for the previous question, lifestyle modifications of IBD, we don't have much data. Like as you are a prominent personality in this field of do you find any limitations to make this into a project like on the same topic? Like any limitations you found? Because any students who are listening this topic can take this as a topic as a research question in their future projects, so you can guide them regarding the same.
There is a lot of work which is ongoing on the diet, right? There was a recent paper from All India Institute that certain forms of dietary modifications exclusive to nutrition can improve outcomes. And there is data in Crohn's disease from West and ulcerative colitis, this kind of data. So on diet, I think there is a lot of work which is going on, and but other lifestyle modifications. Certainly, there are a few studies which have talked about exercise, whether it is feasible or not. But how it improves the outcomes, the data is still not there. And certainly, this is an area where people should work.
Okay, sir. Thank you so much. Okay, so we can wait for further 30 seconds. If we have any questions, we can take. Otherwise, we can come end the session with an end note. Sir, is today your birthday? Sir, I think some of your colleagues has placed a message in the YouTube chat, sir. I think. Yes,
Happy
sir.
birthday, sir.
We wish you a very happy birthday, sir, from our team SMR and Medinware conference. So hope you keep contributing to the science field much more, and you reach very great heights and teach our students like us and become one of the eminent scientists in India. So thank you so much, sir, for accepting our invitation to be an honorable speaker for this topic, which is a need of the hour. So Sir is one of the first speaker who accepted our request. Like at that time, we are struggling to bring good speakers for our conference. So Sir has accepted our request and came forward to support our conference. So it was really a happy moment, sir. Wish you again a very happy birthday.
Thank you so much. And I think as a teacher, it is our duty to always interact with the students, at all levels, undergraduates and postgraduates. And because I have another lecture this week, I could not take up the second commitment which you said, but that is in my mind. And certainly, at an opportune time, we will talk about how to do a meta-analysis. Right?
Yes, sir. We can plan it in August, sir, whenever we are free. So there are no more questions, sir, but we are getting birthday wishes from audience. So I hope they got enlightened on this very interesting topic and challenging topic. Although we are in undergraduates, I feel this is an insightful topic where we can apply it in many aspects during our wards or in future in our clinical practice.
If you see, this is one situation where you can have a therapeutic trial of ATT. People usually discourage therapeutic trial of ATT, right?
Yes.
Here, once you have done all the investigations, colonoscopy, biopsy, histology, and microbiological tests, and still you do not have a diagnosis, you can do a therapeutic under your close observation.
Yes, sir. Yes, sir. With this, we came to the end of this session, sir. So, on behalf of the whole SMR team and Medinway team, I would like to once again thank heartful thanks to Dr. Vishal Sharma, sir, for coming as a honorable speaker for our conference and enlightening us in this topic. Hope delegates enjoyed this wonderful session. Sir, we got 1,000+ views for this session, which will get updated in the real time. Real time views will be updated in a day, and we will also share this session among various medical platforms after this session. And I will end the session YouTube live stream, sir. Please stay for 5 more minutes. We can have a group photo.
Okay, then, good day.